All right, so the maxillary sinus, I feel like this is a sinus that's often seen, since it's often the first thing that we're doing in endoscopic sinus surgery, sort of the first thing that we let residents do. It's often seen as very simple, but actually this is an opportunity where there can be a fair amount of complexity, and understanding really how to incorporate the natural ostium into the antrostomy is really important. Also, from an anatomic standpoint, in the rest of the dissection, identifying the maxillary early really helps with understanding what else is going on. So because the medial wall of the maxillary sinus is often approximate with the orbital wall, it really gives you that anatomic location. Similarly, the posterior wall is really in the same plane with the sphenoid ostium. So again, having that fully dissected towards the beginning of sinus surgery can be very helpful. We talked about this a little bit yesterday, and I think this is also something really from a preoperative assessment that it's important to look at, where you look at that height differential. So when you have a really tall maxillary, it means that your ethmoid is going to be short. Similarly, if you have a small maxillary height, your ethmoids are going to be much larger. That's important for ethmoid dissection, but also for planning your maxillary antrostomy. So the distance that you can actually get between the top of the inferior turbinate and the top of the orbit, or the bottom of the orbit, the top of the maxillary sinus, is going to be very different in these two cases. And that might change how you actually address the antrostomy. And again, a lot of the things that I discussed yesterday, preoperative planning, looking at the actual CAT scan is really important. I showed this scan yesterday, and I'm going to just show a quick video of a patient with silent sinus syndrome where the uncinate is very atelectatic, because again, that changes the position of the actual orbit when you're doing the antrostomy. Similarly, you want to look for a Haller cell. So in this case, you have a large Haller cell that's going to push the ostium forward and down, and you have to know where that is located. In addition, in a lot of cases, you can see how the Haller cell is actually attaching to the infraorbital nerve. And so this is a situation where you have to make a decision about how much of that Haller cell you need to dissect when you're doing the antrostomy, if you need to remove the bottom half of that. And if you are, fracturing it potentially puts that nerve at risk because of the attachment there. So again, those are all things that just looking at the CAT scan beforehand can help with. So the first step is identifying the uncinate. That's sort of, we talked about that yesterday. This is the ball seeker, the double ball probe, to really feel that space, to feel the infundibulum. But I don't actually use the probe to try to actually get into the ostium without actually seeing it. So the biggest thing with this is that the less that you dissect, especially in a diseased sinus, the easier it will be to actually see the uncinate if you uncover it in the right spot. So I use the pediatric backbiter as sort of my first dissecting step, and I try to do that exactly at the level that you think the natural ostium is actually going to be. And the reason that I use this is because you can pull it into the nasal cavity away from the lateral wall, and you don't actually you don't touch the lateral wall at all. You're only dissecting solely the uncinate. Once you do that, I then use the microdebrider to remove the superior portion of the uncinate, so that you then switch to a 30-degree endoscope so you can actually see the ostium before you do anything else. And then you want to enlarge it solely posteriorly. So there are a lot of different ways to do maxillary antrostomy, and I think that's one of the things when we're doing these courses, is that many people have a very well-developed way that they've been doing this for a really long time. My feeling is that there are a million different ways to skin a cat. You have to really be honest with yourself about your own outcomes. And if you're having issues, if your patients are not doing well, if they're not healing well, that's the time to think about potentially doing something differently. But I'm just going to share sort of what I do. So this is the patient who has silent sinus syndrome. This is sort of the same scan. And in addition to having an atelectatic maxillary, you can see the middle turbinate is actually just totally socked over towards the lateral wall. It actually caused a frontal obstruction too, which I'm not going to show that video. So this is that case. And even though this is a very atelectatic uncinate, all right. So the thing that I'm doing differently here, though, even to remove the superior portion of the uncinate, I've already switched to a 90-degree microdebrider, and I'm already using an angled scope. But you can see how I'm solely working only on the uncinate. I haven't disrupted that underlying layer at all. Now I'm going to work closer to where the actual ostium is. And in a silent sinus syndrome, there is really a lot of floppiness of that uncinate. So the suction of the microdebrider helps you to pull it away from the underlying tissue so that you don't actually have any disruption of the underlying tissue there. In this case, I'm using a down biter to now just enlarge that natural ostium inferiorly. And you don't always have to use this. Sometimes you can use a turbinate scissor, sometimes a straight through cut. But in this case, because you want to stay away from the orbit, which you can actually see right here, this is actually the orbital wall that, again, is really much lower than it normally would be. And I'm still using that 90-degree microdebrider, and you can see how floppy that whole medial maxillary wall is because of the atelectasis. And I'm just using the microdebrider to remove the rest of this and enlarge everything posteriorly. So even in an atelectatic sinus, you can still use the same tools. It's just when you are very lateral, using a scope, I'm now using, this is a 45-degree scope that I'm using. And there's just some thick mucus that's inside of the sinus, which is what you typically see with silent sinus syndrome. And you can see that reactive edematous change of the inside of the maxillary. Don't need to do anything further. This can continue to be enlarged further. So you really, as far as how big you need to actually make the opening into the sinus, there's sort of two parts to how you decide and whether or not you want to do something more. One is to think about what you're actually doing. So the next video that I'll show, this is an inverted papilloma. You can see that there's this hyperostotic bone of the lateral wall over here, which you can kind of predispose, maybe that's the actual origination point where the base of the tumor is. You have to think about whether or not you can do this just solely doing an antrostomy or whether you need a bigger opening. Even with an antrostomy, I think one of the most important things is having the right instruments. So curved instrumentation, whether it's curved malleable suctions, those are sort of from the Warmold set, those are one of my favorite things to use, whether you're using a drill, whether you're using a curved microdebrider. Even just with a standard antrostomy as an opening, even for, this is that inverted papilloma case, you can really reach very far lateral and get a lot of work done if the tumor is coming just from the inside of the sinus. So in this case, I'm already using angled scopes, and now this is sort of getting closer to the base of the tumor, using a 90-degree microdebrider to basically remove the bulk of the tumor. And now I'm using the Warmold curved malleable suction, which you can actually create an incision in the mucosa around the tumor so that you isolate the base. Now I'm using a 70-degree frontal sinus curve drill to basically drill away all of that hyperostotic bone that was underneath the tumor, sort of in the area where the tumor was attached. And now I'm just using a curved suction, or a suction cautery that you can bend and obviously use. You can really use that in a lot of different areas within the sinus to, again, address the area of the attachment. So that view is as possible of the lateral wall of the maxillary sinus just with a normal maxillary antrostomy. What about revision cases? So I think one of the most common things that we typically see is that there's either residual uncinate or the natural ostium is not incorporated into the antrostomy. So you have recirculation. So this is something that, if you identify the ostium at the time of the original surgery, the likelihood of that happening is extremely low. There are a lot of other reasons that you might have issues with failure of maxillary sinus disease. So the opening might not be adequate, or there are times that you actually need to extend the opening, make it larger, make a bigger opening, and doing a more advanced procedure. The other thing that I think is really important is this maxillary ethmoid plate. So this back part right here, there's a lot of opening that you can extend very easily by removal of that maxillary ethmoid plate to make the antrostomy larger. For people who are really having issues with pooled secretions that are there that you want to improve the topical therapy. Let's see if I can get this to play. So this is just a patient with recirculation. So you can see some mucus coming from that area. And then you can see there's some residual uncinate. So now I've switched to an angled scope. And it's just a really small band that's right there. So using that backbiter again, right at the level of the natural ostium, you can actually see where the natural ostium is located. And then it just needs to be incorporated into this really huge antrostomy that was already performed. So same idea, but it's just such a simple thing for these patients who are complaining about a lot of really thick mucus post-operatively. So now just removal of that one small band with a through-cutting instrument. There are a lot of different things that you can use. And obviously, that's something that you can avoid by identifying the natural ostium the first time around and really sort of figuring out how to do that so you don't end up having patients with that problem. There are a lot of advanced maxillary sinus procedures. And I'm just going to briefly talk about mega antrostomy, which is something that we'll practice in the lab, or endoscopic medial maxillectomy. Usually this situation is done if there's extensive disease, again, if you need to make the opening larger, if there's a tumor that you can't access, especially in the very anterior aspect of the sinus. So this is a patient who had NK T-cell lymphoma and was treated with chemoradiation and ended up having significant secondary chronic rhinosinusitis, which is just a small patient niche that I end up taking care of and really enjoy. All of that is basically scar tissue, and it's also not clear if there's actually residual tumor that's there. So in this case, we just made the opening much larger, and this is sort of the first part of thinking about doing an endoscopic medial maxillectomy or mega antrostomy, is just removing that inferior turbinate. And these first cuts are always a little challenging just because viewing it with the scope while you're doing it is a little hard, just because you're working in the front part of the nose. Removing that piece of the inferior turbinate first. Usually we like to make a mucosal flap. In this case, I did not do that, obviously, just because she has a history of tumor. So you want to make sure that you're actually removing that. I didn't want to put mucosa back, especially because it was radiated tissue. Once you've done that, you can remove as much of the medial maxillary wall as you'd like. That's just a large side biter. And then you can use, again, some of those angled instruments. This is a 90-degree microdebrider, removing some of the tissue from the inside as well. And again, all this does is really creates a much bigger cavity post-operatively. So one, it really helps just as far as being able to monitor the inside of the sinus. The other is with irrigations, especially in someone who doesn't have really good mucociliary clearance. The rinse from the opposite nostril basically washes into that maxillary sinus very effectively and is able to clear things as well. So this is it's actually very easy to do this, and it really is very helpful for select patients. So with that, I'm going to go ahead and complete. I think for the maxillary sinus, the preoperative CT scan when you're planning is really key. It's actually fairly complex to do a good maxillary antrostomy. So it's something that you do really want to spend some time looking at the CT scan beforehand so you can really plan where the natural ostium is, making sure that you incorporate that into the antrostomy, and then tailoring the surgical approach, one, to the disease process, and then also thinking about post-operative care and how much you need to be able to see into the sinus as well, especially if it's a tumor case. Angled scopes and instrumentation are really key. So you can't work inside of the maxillary sinus without having some of these angled instruments just because you're not able to reach, and certainly you're not able to see things very well without using even a 70-degree scope for most of this. Thank you very much.